ahead and unmute automatically. Switch over there. Hello, everyone. Welcome back to another edition of What's Happening Now with CNI Solutions. Don't forget to like, share, and comment on this broadcast tonight, as we do have a special broadcast tonight, and we will be talking about Brewster mental health.
Yes.
Like this, and we know how important mental health is to us and what we do on a day-to-day basis. But you need to understand how important mental health is to you and what you do on a day-to-day basis, whether it be work, playing, sports, studying, school, whatever it is, it's going to take a part in what it is that you're doing. So tonight's guest, we would like to introduce Miss Dr. Renee Spielman. Dr. Renee, welcome to the broadcast. Thank you for being here. Thank you for allowing us this time. So tell us, Dr. Renee, give us a little bit of background about mental health.
So mental health, historically, let's just talk about specifically to the Black community. Going back into slavery times, the slaves were not thought to be able to possess things like anxiety or depression, not capable of having those kind of feelings. And we're not allowed to have a bad day. There was, like, in slavery, there was no bad days. You just had to stifle that down. And so through the generations, this lack of being in touch with your feelings, or not having information about your own mental health it's just prevailed. It's just gone from generation to generation. And so now, we are kind of, almost faced with this epidemic within the, Black community, because of the stigma that has gone for so long, that our own people are fearful of mental health or out of touch with it, because, of society. I mean, people, look down upon you, or you feel as though people look down upon you because you have a mental illness, and that they equate it with being weak. But there are millions of people who have mental illness. So it's, so the Black community just itself has kind of kept itself in this place of not being mentally well.
Right. Yeah, I agree with you on that wholeheartedly. One of the things that I know I've dealt with in dealing with when I was in the military and dealing with soldiers and their mental health, a lot of times that peer pressure of someone saying that, hey, I need to see my doctor, or hey, I need help mentally, I'm unstable, I don't know what's going on. Peers can be the most, they could be the most damaging and hurtful. They can say the most hurtful things to you when you're going through some things mentally. How should one, conquer that, or get over that?
So, the culture of the military has changed tremendously. I'm a retiree, and so there was, the time where you did not talk about your mental health at all. And now I'm going to say it's a little bit more warm and fuzzy, where people actually, want to hear about what's going on with you. But when you do have a peer, especially in the military, that is not supportive, this is something that you kind of, in some ways, you have to stand up for yourself. That, this is, I'm not being a wussy or whatever, but I am just facing some mental health challenges. The other thing in the military is you have to go on sick call. You have to reach out and go to mental health. Nobody's going to come looking for you, for mental health, because everybody wants you to kind of follow a mission and be fit and be ready to fight. So, the military, it's a whole different world, because there is this mission for you to be able to do your job. And it is what doesn't matter what color you are. If you cannot perform your mission, then people are kind of like, hey, is this guy a good team member? But still, you can still suffer from anxiety or depression, or even have a mood disorder and still be fit to fight. You just have to address that and learn the skills to deal with that. And even now, the military is more agreeable, if a soldier or airman, has to use medications, that they don't lose their job, because that was a real big issue before. I can't take an antidepressant because I'm gonna lose my job. And you're supporting the wife and 3 kids. You need your job. So even that type of mentality has lessened.
So let me ask you: is there any particular signs that a family member or someone can look out for with somebody who might be going through something mentally? How can someone give them help? If they don't know they need help themselves.
So normally, family members are the first to recognize something is amiss with their loved one. So now all of a sudden you have somebody that's, they've changed. Their personality somewhat has changed. Somebody that was outgoing is now isolating. Somebody who's now is moody where they weren't. They're not sleeping well. Or you notice that your loved one is no longer engaging in those activities that they used to enjoy. And that usually kind of more goes along the line of somebody who has depression. And so everybody goes through bouts of depression, in their life. Things make you feel sad. But when that depression becomes a daily thing, and the tone of the conversation with the person also is changing, where they're talking about feeling hopeless and helpless and so overwhelmed that they can't function. And the ultimate is, I don't want to be here. I want to kill myself. Those are red flags that you should start saying, hey, what's going on? Sometimes the client, I'm going to call them clients, will talk to their family. But if truly you are concerned and you kind of feel that your loved one needs help, you need to reach out. Most people, the first place they reach out to is their primary care, because they see the bulk. You walk in the door, you see the primary care, and to get to mental health services, sometimes you need a referral from your primary care. Some primary care providers themselves take care of mental, illness, anxiety, depression, maybe a kind of a stable mood disorder. But it's to go seek out help. And usually starting with your primary care provider is a good place to go, especially when you're dealing with the insurance, because you want that gatekeeper, you want the insurance company to pay for your visits. But just there are, even if let's just say you're not even sure if you want to seek care, you can go. There are resources online, like if you go through NAMI, National Alliance for Mental Illness, NAMI, you can go in there and they have a locator where you can put in your zip code and you can find mental health clinics near you. And you can always go that route and just pick up the phone and call and say, hey, this is what's going on with my loved one and I'm concerned. And they can get you an appointment. But if you feel that your loved one is in crisis, every area has their own crisis number. And then there's a national, like suicide, like 1-800-SUICIDE you can call. So the best thing to do is to start looking for resources. How do I get my loved one some help? Don't just stop at one place. Even if they go to the primary care and the primary care foo-foos it as, oh, he's okay. He's just a teenager. If you're not happy with that answer, continue to seek out mental health resources. Right. Specifically, primary. I'm my background is medicine, and then I went over to psychiatry. Notoriously, family medicine, primary care, they do not have a lot of time to spend with clients. They have a large capacity of people to see in a day. Mental health clients take time because you have to sit and listen to them. It's not just a blood pressure looking at some symptoms. You have to hear a story. And so a lot of times when the client comes in, certain things get missed when you're with your family doctor because of the volume of patients. So if you're really concerned, you talk to your primary care and you feel like you're not getting an honest, or you're not getting the answer to be true because your loved one, then you ask for a referral, or you ask, what can I do to get my person some mental health care? Right. Don't let that be the only answer you hear.
Right.
So, Dr. Spielman, in your with your experience, I heard you talk about the different types of flags, and that red flag is. I remember there was a story about Michael Jackson. His family said that they were trying to intervene, but they got to a point where intervention was not wanted by, per se, the person who was in need of mental health services. What's the extreme? I know you mentioned the 1-800s and things like that, but what's the extreme that you would say when it comes to someone who needs mental health? What do you do?
So the extreme, every state has different laws of how they handle a crisis, the extreme. So in Washington, I can tell you, Washington State, if your loved one is totally out of control, can't take care of themselves, psychotic, aggressive, so they're a danger to themselves, or they're a danger to others, or if they are gravely disabled, they can be evaluated so they can be involuntarily detained for up to 5 days now, so they can be evaluated. Every state is different, because even if you are just the person's in crisis and you're like, my loved one needs help, this is not my loved one. If they come out and you evaluate that person, or you take them to the ER, and your loved one is saying, nope, I don't need help, she's making it up, blah, blah, blah. I will not voluntarily go to treat any kind of mental health treatment. There's a chance they may walk. They may leave the ER, they may leave the court evaluator and go back home. And unfortunately, sometimes you have to wait until they decompensate so much that somebody says, oh, we will detain them. Because you have to remember, the flip side of that is this individual in crisis has constitutional rights to be mentally ill. There's no law that says you cannot be mentally ill. And sometimes people forget that. Even, you love the person so much and you're trying to help, but that person in crisis has rights also. So it's always kind of a iffy, especially for psychosis. If somebody's like, I'm going to kill myself right now with this knife, that's easier to get detained because you have an imminent danger to themselves. But if just somebody is hallucinating and they hear the voice of God, but that's their crisis and they're not bothering anybody, then they probably won't get detained. They'll try to get them outpatient resources, i.e., get them set up with mental health outpatient, to get a therapist, to have a med manager, and potentially some support. But that's a whole different process. But our system right now, you really, really have to be ill to get involuntarily get treatment.
Wow.
Right. My mindset is hot in many different areas there, Dr. Spielman. But let's say that person has gotten to the extreme. I find, and I know, Charles, we watch the news all the time. The extreme is they're already in the act of doing something that's not what they mentally should be doing, or they probably never thought that they would do.
Right.
The system says, well, we can't do anything about it. But we as a loved ones, and I guess more or less, I'm talking to the people, the viewers that are out there. Watch your loved ones. If you're around me, watch me.
I think Huntsville has on your you have a crisis line that it doesn't have to be the patient. Anybody can call. Just you can to even report that my loved one is in crisis, and they can kind of guide you where to go. Of course, if all else fails, and it's always an iffy, especially if you're somebody of color, but you can always call the police, and that varies, because some places for mental health you feel very comfortable because they'll come out there and maybe evaluate, but a lot of the police are getting hands off on mental health because of all of the other bad press. I know here they've been called out on mental health calls, and then somebody gets shot, and that's not how it works in mental health. You don't shoot your patients who are psychotic. So it's always just kind of usually by the time somebody calls the police, they don't know what else to do.
Right. So
They,
let me,
they can't handle it and they don't know what else to do.
Dr. Spielman, if you may, let me ask you something. And in today's age, we have a lot of social media. And on that social media, there's that one thing that everyone loves, what's called TikTok. Now, what I have felt since I've been watching TikTok and looking at these videos and watching certain things, I have felt my mental state change on how I view things now and how I look at things, because I've seen so much senseless killings of African Americans, unarmed, especially by police or anything like that. Or I see an African American who did something get charged an extreme amount of years, whereas somebody who was non-African American did the same exact thing and don't get charged. It has affected me. Is that something that is normal, like this, does to affect people like that, to make their mental state change?
Of course that's normal. Of course that's not normal. It's like you're watching trauma, repeated trauma over and over and over again. The injustices, the inequities. It plays in your mind because this is the reality we live in. This is not made up stuff. This is reality, and you're expected to kind of somewhat filter through it all and cope with it and deal with it. And not everything you can swallow. Not everything is like, oh yeah, I understand how this works. No, the cards are stacked against people. It's horrible. I mean, I work in mental health for a living, and I listen to people and what's going on, but I have to check my own mental health. I mean, just after the shooting yesterday, I was in tears all evening thinking, how cruel someone could be to go into a school, and you yourself, I mean, there's like no magic. Oh, I got over it today. No, I'm still very sad about it. I'm still very angry about it. And you just have to work with what you have and recognize and be able to express your own feelings, get support, talk to other people who are dealing with the same thing. Because what happens is you realize your feelings of being overwhelmed, and almost you feel isolated because you're hearing this and you're wondering, does anybody else feel this? And you realize thousands of other people feel the same way. And that's that connected feeling. Doesn't make it go away, doesn't make it right. It just means, okay, I'm not losing my mind. This all is terrible.
Right. Coping. I think coping is oftentimes what we do. We cope with it instead of possibly reaching out and seeking assistance. I'm one of those who has managed to cope with things that have affected me over the years. And I sought some mental health assistance as well. But is it a norm that medication is in the foreground when it comes to treating someone with mental health disorder? Or
I mean, it just depends. I mean, so for mental health, the Bible that tells you whether somebody meets criteria for a mental illness is called the DSM-5. And so it just has all the criteria. If you're schizophrenia, what you have to possess for me to give you that diagnosis. Once you have a diagnosis, which I don't necessarily always provide medications just because of a diagnosis, I'm trying to treat the symptoms that person has. Medications is a part of that, but for everyone, medications, especially if you're voluntary, medications are an option to help you. Medications and counseling, that's what they always say, go hand in hand. The medications will help you stabilize, but the counseling is going to help you deal with what's going on in your trauma, learn some better coping skills. Just like for people who are cutters, they self-harm. A lot of that has to, that self-harming, that cutting is a dysfunctional coping skill. It's relief to them, not necessarily I'm trying to kill myself. I'm trying to change the pain, But when medications come up, your prescriber should be talking about the pros and cons. if your symptoms are such that they're interfering with your daily life, you can't work, you can't hold a job,
Yeah.
you can't pay your bills because you're gambling too much. When you look around you and you see what this mental illness is doing to your life, and medication, that conversation comes up, that's when you have to start saying, am I able to handle this without medications? Because there's a reason why you've landed to see me as a prescriber. And I'm going to talk to you about the pros and cons and then try to give you an objective idea of, okay, these are all the things you just told me in the past, hour. And I'm going to say you meet criteria for this diagnosis. For everybody, this is generally how we treat that diagnosis. And if you say, well, Renee, I don't want medications. And then I'm going to say, okay, so what are your plans? How are you going to deal with this? And maybe the first time or second time, I may not even prescribe for you because it does no good for me to prescribe something you won't take.
Right. It looks like we have a couple questions, Dr. Spielman. Producer, can you put the first question up for us? What is your take on the stereotypes that versus the African American community and are not, is that recognized to the counseling, seeking help for mental health issues? Did you get that, Dr. Spielman?
Well, I don't know if in general they are not any more receptive than, let's just talk about the African American community. I don't even know if they're offered as often the counseling, as let's just say their white counterparts. I think I had a statistics about, I think 1 in 3 Black adults who need care don't receive care. And I think if that was put on the table more often, like this counseling is available to you, this med management is available to you, I think we would see more, Blacks using that opportunity. But when there's a lot, because this whole thing is fraught with all kind of problems, when there is a lack of access to care anyhow, as a Black person, if you're trying to find culturally competent care and you want another Black person taking care of your mental health needs, the chances of that are pretty slim. So if anything, I would say as, a Black woman, the resistance would come from thinking I'm going to have to go talk to somebody that doesn't know me culturally about these deep, dark secrets that I have. Yes. Related to my culture, related to myself. And yes, maybe I will be a little bit more resistant because I don't want to talk to, Tammy from South Dakota, who's never talked to a Black person.
I'm a veteran as well. And at the VA, I had that on my first visit. I was not comfortable with my care provider at that time. And, but it did get better. What got better is me as the patient, when I began to release the things and I hate to say it, but kind of trust the process.
Yeah.
And the process says that you speak about it, right?
And not every therapist or med manager for that matter is going to be the right fit. Sometimes you have to oh, you know what? This person I'm not bonding with, do you have another therapist I can talk to?
Right. Yeah,
and I think culturally we are not taught to kind of challenge that and ask for that second opinion, or hey, we're not bonding. Can you refer me to somebody else?
Mm-hmm.
Right. Another question that was asked, Dr. Spielman, says you mentioned that a person could be involuntarily held for up to 5 days, and is this different from 5150, or has the 5150 threshold changed from 72 hours to 5 days?
Correct. Well, and I don't know in Alabama because I'm in Washington State, but yeah, we used to just have the 72-hour hold, and now it's a 5-day hold, and it may be the same thing. Yeah, so now we have mental health hospitals and crisis centers that you can go in the door voluntary, or you can come from the ER, let's just say involuntary,
Mhm.
not involuntary, let's just say voluntary. Within that time, if the patient, there's some concern that this person is not well enough to walk out the door, and be a voluntary person, then they can have a court person detain them. In Washington now, it's a 5-day hold. It used to be 72, so it's probably the same thing. You're 5150.
So you mentioned something that I found interesting when you mentioned something about people or persons who cut themselves, and you said they cut themselves as a means of
Coping.
of taking a different pain. So there's a lot of what type of examples would that be, ma'am?
What do you mean?
So if like, what type of pain would they be trying to run from if they're going to start
like
cutting themselves?
emotional pain.
Okay.
A lot of times it's emotional pain, like if they're anxious or they're overwhelmed or they can't deal, the patient can't deal with the situation. And I'm not saying that all clients who cut are just doing emotional, because some clients who cut have a personality disorder and they might be cutting I'm going to show you how much you hurt me, and I'm going to cut myself. And sometimes good old fashioned people cut themselves because they want to kill themselves.
That's true. I've been in a neighborhood where that seemed to have been could something like that possibly trend?
Well, I'm sure you see it more in your younger clients. I'm not saying people can't chronic, but that you see a lot more in the younger. And I would imagine, young group of people, some of them get together and probably cut together.
Yes. I have found that to be true. Let me do a quick switch from the male perspective. Well, male versus female perspective when it comes to mental health. Do you find it more? What do you see the numbers, male to female, those who seek mental health assistance? Because I'm a male, and I have this thing sometimes called bravado. And
I'm going to say, just without knowing the statistics, that women seek out mental health more than men.
Right.
Outpatient, I see more women than men, but inpatient, I see more men, and mostly inpatient, they're involuntary.
Is that because the inpatients have waited too long to seek help?
Yeah. So a lot of times, and it's so interesting because even outpatient, if you start wanting to talk about African Americans or blacks versus whites, outpatient, you see, I would say statistically, maybe 30% are black. Inpatient, flip that around. I'm going to say a good half of my patients are black inpatient, involuntary. So more likely to, and so now you see someone who it took them a long time to get into the mental health system. They're a little bit older, and then now they're faced with the economic stuff, the homelessness, and they just kind of don't, or see a lot of men who have come from prison who have mental health issues. So inpatient, I see a lot more, black people inpatient, and they're involuntary.
Okay. We have another question, Dr. Spielman. What is the difference in personality disorder and mental health diagnosis, and how is this
line drawn?
How is this line drawn to differentiate the two?
So a mental health diagnosis is the big umbrella. It's just called mental health, and then there's a diagnosis. Within the diagnosis, I don't know, there's, let's just say 50 different, probably more, diagnoses, and borderline personality disorders one, antisocial. So there are different types of personality disorders, from borderline personality disorder to antisocial personality disorder. So just like depression, you can have somebody with just mild, just a regular depression, or they can have a recurrent depression. They can have a moderate to severe with psychosis. So there are different broad categories underneath the mental health umbrella.
Right. Okay. You mentioned something in regards to depression, and remember how I told you there's a lot of myths out there, especially in the African American community, about when someone's going through some type of mental state and how they feel, and how their peers or family members will say, "Oh, there's nothing wrong with you, get over it," and why are you acting like that? So one of my things that I would always say, if someone told me they're depressed, I'm in a depressed state, and they never actually seeked any type of help, I would always ask, how do you know that? How do you know you're depressed? Can someone actually know they're actually depressed without actually going to seek any type of medical help for their depression?
Of course. I mean, depression, anxiety. I mean, even when you come in to see this mental health prescriber, and most of people, when they first walk in the door, the first thing they tell you is, "I'm depressed." All I'm doing is diagnostically confirming probably what they already know. So yeah, of course. Now, the interesting thing though is a lot of times when clients are psychotic, like they maybe have been on meds, they've been stable, and they stop their medications, and you always wonder, why didn't you go back on your medications? You started hearing voices, you're paranoid, you saw the medications working, what happened? And over again, clients will say, number one, they didn't want to take the medications, but then they did start getting ill, but they got so ill, it was like mentally they couldn't find the logic back to restart their medications. So it's different when there's psychosis on board. Clients, and especially if somebody's manic. So this is a person, they have a bipolar or a mood disorder, and then this is the manic part, is where they're elevated. They're smarter than anybody in the universe. They're talking really fast. They spending a lot of money. Most clients who are manic are happy. They don't want to be medicated. They don't want that sunshine to go away. So as a prescriber, it's hard to sell a manic person on medications, because they're talking really fast and thinking they're smarter than they will tell me, "You're stupid. You don't know what you're talking about. I'm smart. Everybody in this room."
Right.
It's hard. It's a hard sell to get that person to understand. You need to be on medications. You need to slow down. And I mean, you have to humble yourself. Like, I understand how smart you are, but the rest of us on this earth are only this smart, and you're this smart, and you got to bring it down so we can communicate.
So a manic depressant, as you've described, to get them to come from happy land down to you mere mortals, mediocre land, is that necessary since they're in happy land? Are they, or should I say, I'm sorry, Dr. Spielman, should I say, are they a danger to anyone?
Not a danger to anyone necessarily, but like, especially if somebody's really, really manic, it's not that so much that they're a danger to somebody else, but this person no longer can take care of their means. So the patients I see, inpatients who are manic, this person has been walking. They walk, 50 miles in the last 3 days, barefoot, no food, no shelter, just talking and walking. Wow. They're busy.
Wow.
Right.
That, that's too far. That's too far.
Yes.
So you want the person to be able to take care of themselves, to be able, even if, because they're inpatient, some of the clients don't have a place to go. They will discharge homeless. You want to make sure that they at least are going to go back to their tent and sleep in their tent. It could be in the middle of winter, and that person basically might not have anything on but a bikini, and one sandal.
Right. All right. Looks like we have another question, Dr. Spielman. Is having an attention deficit or hyperactivity disorder a type of mental health issue?
Yeah, it's diagnosable under the DSM-5. You can have just attention deficit disorder or attention deficit hyperactivity disorder, but both of them, it comes under mental health disorder.
So, and my children, when they were younger, they were diagnosed with ADHD and ADAD.
Mhm.
I'm sorry, Joe. Was that because of DADDY?
It probably was. But I had a firm belief, Dr. Spielman, and I have a firm belief that medicine, for me, medicine wasn't the answer for them. To me, the medicine what they needed was that paddle on that backside, and that would straighten them up. That's what I thought would work, because I get called to the school and their mom would try to tell me, they got ADHD. That's no, they don't. What they need is this right here, and they'll straighten right on up.
So, but Dr. Spielman, what you did say earlier, you said cultural tradition.
But did that paddle fix that?
To me, it did. They never had no problems no more. I didn't have no issues.
Okay.
So, we've come a long way. I mean, I'm, probably from your generation. But, it's a diagnosis. I mean, I'm not saying because you have ADD or ADHD throughout any discipline you ever might have for your child, but you're supposed to be looking at, there's social skills, their school skills, and how this is interfering. If you have the problem is, when you have a child that gets so far behind or left behind because they can't focus, because of their inability to concentrate. And sometimes I'm not saying that, some kids are not, lazy and not doing their homework and, don't want to, but you do have to seriously look at what's going on with my child and being aware when you watch them do the homework. Is it just the fact that, they're here, there, 1 minute they can't find their pen, then they can't find their book bag. They spend more time trying to figure out how to get organized than they actually do working, because their brains won't slow down to let them process. And not everything has to be medications, because they can go through group, in groups to help them do activities to help them make better choices, to not be so impulsive. I prescribe for a living, but I am not a firm believer that a pill fixes everything.
Right.
Oh,
there's
okay.
there,
No, she said a pill doesn't fix everything. She didn't say the paddle.
The only thing I heard was the P.
I used to use that.
I mean, it just depends on your what's going on in the situation. But I do know, if you're seeking another answer, another option to help your child, your loved one, then looking at medication management is not the end of the world. And I think that's in our community, that's kind of a part of that problem, is because we are so used to getting something out and spanking it out of them.
Right.
Yeah.
And it doesn't have to be that. It doesn't have to be that way. There might be other options, but I do not like to think that the mental illness is used as a crutch, that now I can't do anything with my life because now I have this diagnosis. So that's why I'm, I if I want to get reimbursed, I have to give you a diagnosis, but I do try to stay away from that diagnosis guiding everything we talk about and do.
Excuse me for a second, Mr. Fong. I know you had a question, but you touched on something that kind of hit home for me. How do you address somebody who tells you what they are? For instance, if someone has an anger management problem and they're taking medicine and they say, oh, well, you don't want to mess with me right now because I didn't take my medicine for my anger management, and I might just go totally off on you, upside down, upside one side, down the other. How is that? I mean, how can someone say that?
Easy.
People say that and more. Your response to that person is, okay, take your medication so we can talk. Because if you need to communicate, if they're prescribed medications, they may need it. But challenging somebody in that situation of kind of like belittling their mental health, it only usually makes things worse.
So we you should really say, well, hey, go ahead and take your medicine and come back so we can move furniture.
Yeah, if that's what they need, it's like, hey, go ahead, yeah, go ahead and take your medication. I feel you. Acknowledge that person. Hey, I feel you. I hear what you're saying, and glad you have a solution. Go take your medications. Check back in with me. Now, in this line of work, unfortunately, you have people who use their mental illness as an excuse for bad behavior.
Yes. Right. Yes. So
that was my thing. I felt like they were going to use that mental health issue as a means for bad behavior, as their excuse to do what they're about to go do. Well, I'm ADHD, or I got an anger management problem. I don't care about that. I got 2 belts, right? That was my thoughts when I'm being told that.
Right. Well, but you know what, Dr. Spielman, I do find that in today's culture, children, young people are a little bit more educated than what we were when it comes to mental health. And they also know lines. But I do not think that the mental health issues and crisis is any much different, and maybe even worse than when during my decades, right? So that's just my thought on that. But that's I think that's it lies a lot in the culture when it comes down to that. Charles?
Looks like we got a couple more questions for you, Dr. Spielman. Producer, can you put the question up? What was that? It went too quick.
What is
Can you put it back up?
Teletherapy?
What is teletherapy?
Teletherapy, like when the only teletherapy I know is like when you're doing like this, when you're seeing somebody via video. I don't know of a different therapy, like just it's a video therapy. I don't know this one other than video, like telehealth.
Right.
It's like telehealth.
Yeah, because I know the VA offers that, and I have an appointment on the 31st, Charles. I won't be available.
Yeah, so it's just seeing your prescriber, your therapist, your counselor, or even attending groups online in this type of a forum. Like I see people outpatient via telehealth.
Okay.
I think that's the question.
Another question that was asked, once kids have been medicated at a young age, how do they deal with ADHD as adults?
So, there are a lot of adults treated for ADHD with Adderall, with Ritalin, with Strattera, with Concerta. They're meds. Unfortunately, there are a lot of adults who were diagnosed as children who go off and end up using meth. And that will be what they say, because I was given a stimulant as a child, and meth is a stimulant. And so they, use street drugs, and they'll use methamphetamines. It's treatable as an adult. I mean, they just, have to meet the criteria and have a provider that will prescribe for them. Stimulant medications are have high street value. So, so they're controlled. So, prescribers are very reluctant, just like, oxycodone.
Right.
Patients like oxycodone for themselves, and it's got high street value when you can pay, you can sell it for $5 or $10 or $20 a pill. So, wow. But yes, it can be treated just ADHD or ADD can be treated in adult just as it can be in childhood.
So, and I got one more question on that, Dr. Spielman, and I don't know if it's because of the culture that I live in and the surrounding areas that I've grew up in, but in your line of work and what you do you find that more African American kids are diagnosed with ADHD versus non-African American kids?
I can't really answer that because I'm not around kids anymore as much as I used to be. I'm actually around adults now. I don't know. I don't know the answer to that.
Yeah.
Okay.
Is there another question on the board?
No.
Okay. Okay. Well, awesome. There was awareness. I know that Charles and I and we've kind of shared a few laughs together. I personally want the community to know, our community of viewers and the viewers in the future, because this digital world, this will be out there for some time to come.
Right.
Mental health awareness and seeking mental health assistance is very, very important. I went over 50 years without seeking it. And since I did seek it and I sought after it, I find that I do have a happier place.
Right.
And I do not feel as though it's all contributed to meds. But one of the things that I wanted to ask earlier was, we talked about prior to coming on air, the clergy. I know that there's some clergy that have the credentials, but just let's say overall from the clergy, do professionals feel as though that the clergy have a position in this line of treatment if necessary?
Oh, yes. Oh, of course. Because, this is someone that you trust, that you can talk to, that you can share. And so it's a source of solace, of peace, to go to talk to your clergy. But at the same time, if the symptoms are such, even after talking to the clergy and praying on it, that they continue and they're affecting your life, they're affecting your relationships with your family and things like that. If the picture is bigger than just that conversation, you have to be willing to. You can still keep your clergy. You have to give up your clergy to seek mental health treatment.
Right.
But go seek treatment. I mean, if the praying is not making it well enough for you to live your life and you need to seek treatment, you can. Like I said, medications, yes, are a part of the conversation, but they're not the only thing in mental health. There is counseling, individual and group. But it's nice to know that there are medications out there, just like somebody who's depressed. When they come to me, let's just say they rate their depression fairly high, and they're a little bit resistant to starting antidepressant. Oh, I don't want to be on meds for the rest of my life, or what is this going to do to me? After you explain the risks and benefits, and one of my things I say is, if you agree to start this antidepressant, I want you to be able to say, I'll take it for at least a year. And during that year, you need to go to counseling to deal with your trauma, to learn some better coping skills. You're going to get equipped. So in a year, if you want to try to wean off, we can start taking you off the antidepressant, because the antidepressant will help you with the counseling. You'll feel better. But some people don't want that lifelong, I need antidepressant. So if you want to give it a good try, wait that year, and then we can slowly wean you off and see if you can do it without the medications. Not everybody can come off the medications. Sometimes you don't make enough serotonin and you're just depressed. You're doing all the right things, but that's still going to make you stronger than you were before if you just go through those steps. And when people can kind of see a quantifiable number, they're more willing to engage. But there's no guarantee at the end of the year you will get off medications, but there's a chance you might be able to try.
Right.
One follow-up there, Charles. I saw you getting ready to ask a question. What in your profession, what is the Achilles heel, if there is one, that you can speak of?
As far as what, treatment or?
Right. The treatment, reluctance, when it comes to cultural differences, what you see that can be, sometimes I believe, and let me just throw this little piece in there, right? That there's someone out there that's about to, I won't say create, they're about to put together something that's going to bring the minds of those who are needing mental health together. I think there's so many dynamics that exist. And there are those that are in your field who have these great ideas that say, well, we can do this better. I think the biggest challenge right now, if I had to say anything, is the co-occurring disorders. People have mental health issues and substance use disorders. Substance use is running rampant out there. We have a drug problem like nobody's business. Pick something and they're manufacturing it, whether it be meth or the fentanyl.
Just, there's so much of that. And I mean, there are synthetic drugs that nobody even knows about now. And, people are becoming psychotic. So now you see a lot of individuals who are acutely psychotic, no mental health history, but they kind of look like they have schizophrenia, and then you're trying to figure out what's going on. When it's an acute episode, it's really easy to say, oh, this is drug-induced psychosis, because they don't have any mental health history. But because this drug epidemic has been going on so long, now you have these clients who have been in and out of psych hospitals every time they get psychotic off of meth. Mm-hmm. And they carry these diagnoses like schizophrenia or schizoaffective disorder. And it's hard to tease out, the chicken or the egg of why they are psychotic now. You don't have that real nice, pretty picture that you'd love to have. And so it's very, it's really difficult. I mean, you can still treat the person, but at the same time, this person who now is in your lane of psychosis also has a drug habit that's not being attended to. And so incorporating that in your day-to-day practice of getting people into getting an assessment for their drug use and getting them into treatment, to me, is kind of like a priority that we cannot afford to miss that opportunity anymore.
So, look, viewers, those who are out there, I hope you are paying attention and really listening to this. Please take time to share this broadcast for someone in your family or friends that you might know who can listen to this information, might need some of this information. As always, there's another question we have. Dr. Spielman is coming up. It says, can you be addicted to the meds for depression? And if so, how do you come off of them without going through withdrawals?
Okay. So it's not necessarily called addiction. Addiction, when you're taking your antidepressants and you go through with withdrawal. Addiction has more to do with there's like different criteria, like you're taking the meds when there's no reason to take the meds, or you're engaging in risky behavior and to take the meds. That's more of addiction, but you can develop a dependence, a tolerance to your antidepressant. When you want to go off your antidepressant, like most medications, if you stop it abruptly, if you say on Monday you've been taking your antidepressant for a year and you're like, I'm done, and you chuck it, you're probably going to go through withdrawal. You're not going to feel good. You're going to feel nauseous. You're going to be feeling dizzy. Some meds like Effexor, venlafaxine, which is an antidepressant, it's probably one of the worst ones to wean off of. And so that one, if you start missing doses, you go through withdrawal. You do not feel well. So it's always recommended that you taper off of them slowly. Like, let's just say if you're on 40 milligrams, go down by 10 milligrams for a week, then go down to 30 milligrams for a week. It may take you a month or even longer to wean off, but it's better than chucking it. A lot of times, by the time the client comes to me and says, well, yeah, doc, I really don't want to take this antidepressant. I don't need it. Once you get to the real root of the conversation, you already find out that they haven't been really taking it every day anyhow. That's fine. Because I say, just tell me the truth. I don't want to medicate a lie. Just tell me the truth. So we can get through what we need to do to help you. And then I will write them out a taper of how to actually taper off the medication. So let's just say you get down to 10 milligrams and all of a sudden your symptoms come back. You're feeling depressed. You're not feeling good anymore. Then I'm going to recommend you need to bump back up to the last dose you were stable at. And then maybe we need to slow down your wean. But clients do it all the time. I mean, even especially inpatient, involuntary people, they finally get done with their time and you tell them, do not stop your meds. You're going to get sick. And, they're throwing it in the garbage on their way out the door, That's life. I mean, I cannot control you when you walk out the door. Only try to help you understand the benefits of being stable.
Right.
And sometimes, clients, they will have a reason to stay mentally well. Like, the state has your kids. Do you want your kids back?
Right. Ooh.
Take your meds. Be stable.
Right.
Don't get police reports that you're running down the street naked with a machete. That won't get you your kids back.
Yeah.
Right.
Wow.
Right.
Uh,
Looks like there's another question. It says, if you have a mental health issue and you don't have insurance, is there a program or doctors you can still get help?
So I can't tell you about Alabama. I can tell you in Washington State, they use the insurance exchange, so everybody can have healthcare insurance. There's 5 top state funded healthcare insurers, and that's the medical insurers provide mental health. In the state of Washington, people who don't have money, they're on state insurance, have better access to mental health care than anybody, because
Wow.
most of the programs are set up for the low income, below the poverty level. If you don't have insurance, I'm not, because I don't know how Alabama works. A lot of mental health places, of course, take out of pocket. A lot of private psychiatrists don't want to deal with state insurance or anybody's insurance. They just want to charge whatever they want to charge.
Right.
That's a route, but that's expensive. The average person cannot afford, $180 a visit or 150. It's not feasible.
Right.
So I don't know, how does Alabama state insurance work? Do they have I would assume they have a state Medicaid insurance.
yes.
They do, and I think that would be something that we would have to look into. From what I understand, and talking with Dr. Fry,
Mhm.
she's mentioned several times that the state insurance here in Alabama really is not as good as people might think it is. As she's mentioned, she's been to different states like in Virginia and Maryland, where the state insurance is a lot better in those states. So I'm not too sure how it is here in
Yes.
Alabama.
So if there's a healthcare, if there's a healthcare exchange within the state, you can always go through that route, trying to see if you qualify for state funded insurance. And also, especially if it's like not a private practice, but like a community healthcare, a community mental health clinic,
Mm-hmm.
call them, because a lot of times they have people, they're called navigators here, that will help you get insurance so you
Okay.
can get care. So I think probably just reaching out and trying to find out if there's navigators or people that can help you, especially if you need mental health care when you're inpatient in the hospital. Let's just say for whatever reason you go inpatient, there are social workers who actually get your insurance started for you so they can pay for your visit.
Okay.
Okay. Looks like we
Yeah.
got another question for you. It says, that's a long word. Is
Venlafaxine
venlafaxine?
75 hard to come off of?
Yeah.
That's not a very high dose, but you have to be able to. A lot of times you have to be able to get down to a 37.5 tab, so you can wean down gradually. I would say start cutting it in half or have it prescribed in smaller doses, so you can start gradually tapering off.
Right. Okay. All right.
But yeah, that the person that wrote that, when I was talking, that venlafaxine is effects are the one that I said, ooh, that one's kind of a little bit harder. It's rough to come off. Yeah, it's a good antidepressant. It helps with anxiety, but it's just one of those that's a little rougher than say like Zoloft or citalopram to wean off of.
Right. So I just got one final question, Dr. Spielman, and I was asked this many years ago. Is outside of your normal circumstances, is homelessness a type of mental illness?
I mean, it's not a diagnosable. I mean,
What I mean by that is outside of, you lost your job and you was a sane person, you was working, you lost your job and you had nowhere else to go and you became homeless. But for someone who, if you just speak to them and they tell you, oh yeah, I got a degree in rocket science, and like, then why are you living on the street? Is that a type of mental disorder?
Not necessarily. I mean, you find people who are homeless have a higher rate of mental illness, but not everybody who chooses to drop out of society and live in a tent is mentally ill.
Key point: drop out of society. Thanks. Another note. Writing.
So and I have clients who, even though there is a homeless crisis that I do believe in, I have a lot of clients that choose to be homeless. They don't want to give up their state benefits for if they're not going to pay for an apartment. They don't want to pay for a place, and they want to do what they want to do. They want to use their drugs freely. Most apartments won't even let you smoke. They don't. They want to be in a place that they can smoke cigarettes, and they choose to live that life. On the other hand, there's a housing crisis for other people who, lost their job and they have kids and they can't get a place to stay. They don't have a choice. But they're people are now recognizing finally that there are certain people who that's what the lifestyle they want, or they wouldn't mind something different, but they're not willing to give up certain things to fit.
Right.
Why can't I do heroin in my apartment? It's like, why are you telling people you're doing heroin in your apartments? Shut up. But they have housing interviews and they ask them, hey, are you going to do drugs? And it's like, well, of course I am. You're like, no, don't tell them that. So, sometimes it's a choice. I mean, everybody has a choice.
Right. All right. Thank you. Viewers, if there's anyone else out there, any more questions, I think our producer will probably we'll get to them. If we hadn't got to your questions, we'll make sure that we get those to Dr. Spielman and try to get them answered for you. But Dr. Spielman, I cannot thank you enough for your time. I cannot thank you for your education, your experience, and sharing this information with us and our viewers. I'm sure our viewers are grateful for it. You've answered a lot of my myths. You've answered a lot of my questions that I've had, and those stereotypes of African Americans and getting help, mental help. It is a good thing. And kind of like my colleague here said, after he started getting that mental help, he felt better. He feels better. And it's a big change for him.
Yeah.
I think more and more of our people should take pride in the fact of having a therapist. Of having somebody you're checking in with about your mental health. It shouldn't be a bad thing. It should be like, my therapist, I have been working on, these certain skills. That is it's like an elitist thing to say, but not everybody has that opportunity. It's like, take advantage of the fact that you have a go-to person that's kind of like a life coach that's trying to help you deal with your emotional we all have so much emotional baggage,
right?
Relationships, trauma, everything. Isn't it nice to be able to know that you have somebody that's paying attention and trying to help you sort through that so you can move on with your life?
Wow.
Right. I will say, my last comment is that, especially for veterans that are out there, and obviously, I think all three of us are veterans. There's a soft spot there for myself because there's so many veterans that haven't thought or are afraid to seek. I will say to you, hey, it's okay. I did not think it was okay, but it is okay. Some people think that I might be on something, maybe a little bit, but I have a happy space. There's a space, there's a block that has been checked, so to speak. Right. And I appreciate that checking of that block. Everything there are things that I think about that are in my daily space where I say, okay, there's possibly an attributing factor to that. And in the past, I would say, the H with it,
veterans are so special in that sense, and I even have to admit, I found myself after I got out of the military and thought about working with the veterans, and this is pretty sad to admit, I was concerned that I wasn't sure if I was going to be able to grasp the warriors as kind of broken. They're not 100%. They have issues. I'm like, I'm used to all these people who are fit to fight, they don't have issues. And that was kind of really hard. I mean, now I get it, but it was kind of a hard transition for me to see active duty and veterans as, at first I think I used, my mind, it was more like broken. Now I see you've gone through some combat, you've gone through, things that need repair, you need help. But it's just that different, that culture, you grow up in that culture, even in the military, of you're not allowed to be mentally ill. You can't have those problems. So, now it's more of kind of like, if we want our soldiers, our people, to go out there and fight and do all the things we want, we have to be willing to understand there's a price to pay, and they need support.
Right.
Nobody goes back to back to back tours and doesn't walk away with emotional trauma and scars from that. It just does not happen.
Yeah, absolutely. And we who have done, I remember the first Gulf War, and there was a soldier in the officer corps who was, now I see it, they were experiencing some mental health problems, and they were made to deploy. You're going to deploy, and when they got there, they continued to experience them. There was more than one soldier, but like you said, being fit to fight and understand that it's a fighting force that can't slow down for mental health. When it comes down to it, you have orders, you get on them.
Right.
Well, but I think the military, or because I'm not in there, active duty anymore, but I think they're starting to recognize that if you don't take care of a soldier's mental health, or airman, look, we just had a couple months ago a number of sailors, kind of a group suicide thing on the ship. This is not very long ago, and you're having more sailors and soldiers coming forward and saying, yeah, I had all these issues, but I couldn't go to my chain of command. Now, back in the day, the chain of command is like, I don't even want to hear that.
Yeah.
Now, there's that shame, which is good because they deserve it. That shame of the chain of command of, why didn't you take care of that? Why didn't you address that? Which is excellent, because the culture will not change until people understand, yes, it matters when you ignore, say, the female who says, hey, I'm being bullied, I'm being harassed by the male soldiers,
Right.
Because before it was like, hey, this is a man's world, you're gonna have to deal with it, sweetheart, grow up. And now, you're realizing, well, maybe it's just a little bit more than her having to grow up. How about the male counterparts not being allowed to bully women, or taking it serious that this person is getting ready to have a mental breakdown. I mean, I've seen patients who were like ordnance technicians who were got all this money to go in the military, but didn't realize every day they were going to be dealing with bombs, things that explode, and they're like, I can't do this. Nobody understands. I'm freaking out. And you're trying to calm this person down, like, okay, instead of trying to kill yourself, what steps can you do, to figure this out? So, you're either going to potentially have to get out of a chapter that's not very favorable, or even just take the steps to get reclassified. But sometimes when you're in that tunnel vision of, I can't do this anymore, nobody understands. And there's that fear of go in the military, going to the mental health, because they're afraid they're going to report it to their chain of command.
Right. There's still this thing called retaliation. And I know when it comes to mission readiness and unit readiness, you're part of that with that MTO, so to speak, that number.
Yeah.
When they don't have their numbers, it affects mission.
Right.
And I know maybe everyone in our viewers don't understand it.
But nowadays they're finding out it's not just the quote weak who have mental health problems.
Yes.
It's your super. Back in the 70s when drugs were galore back over there in Germany, they realized they had a drug problem, but they thought, it was all these younger kids. Not once they pull back the curtains and realize we got a whole corps-wide problem, worldwide problem with drugs and our soldiers. It was a whole different conversation.
Yes.
Right.
So just I think mental health, it just needs to be out there, we're all struggling. We all have mental health issues. Not everything needs to be diagnosed and put in a box and medicated. But golly, getting into some therapy and some counseling, or having a support group, a support system that will help you, and a support system that not saying, girl, you need to stop talking about all that mess. There ain't nothing wrong with you. That's what we have to stop.
Right. I agree.
Last question.
Nope. I'm good.
Last question. So you only treat within the state of Washington. Is that correct? Okay.
Yeah.
All right. So if you're in the state of Washington and you need some assistance.
There you go. Hey, viewers,
Please,
those y'all out there, I know we went a little bit longer than our normal broadcast, but hey, it was some good information, and we cannot thank Dr. Spielman enough.
Yes.
And again, please go ahead and share this broadcast, comment, like this, and put your questions in the chat if you have any for her. Dr. Spielman, do you have any closing remarks, ma'am, would you like to leave us with?
No, just thank you for having me on. Just make sure you check your local mental health resources. There's also National Alliance for Mental Health Illness called NAMI, where you can get a lot of information. There's also another organization called SAMHSA, SAMHSA. That's a national one that you can get resources about locations and all kind of stuff. Don't keep yourself in that little tiny little box. You have to get out of it and check and see what's available. Thank you for having me.
Yes, ma'am. Yes, ma'am. All right. Mr. Farby, any closing remarks, sir?
No. I just have lots of notes, and I appreciate the information. And I'm glad that I'm able to share, because to share things that I've experienced and had to make a decision to do.
Right.
So, like I said, make that decision. If you need it, go and get it. There's a way.
Outstanding. All right. Hey, team, thank you all for joining us. Until next time, always remember, your yesterday is not your today, and your today is not your tomorrow. Good night.
Woohoo.